Good evening, everyone. I'm Melinda Irwin and Hallie Moore, and welcome to the Survivorship Committee. We are excited to share with you today a number of new concepts, some currently enrolling concepts, and also for our guest speaker to share with you his experience in research in cancer survivorship, EPROs, and his vision for cancer survivorship. To get us started, I have no disclosures. Hallie has those disclosures listed there. Just to briefly remind you, we have 5 NCORE committees, so we always like to share a little bit about what our priorities are so that you understand them compared to the other committees. Not that it's a problem if there is a little bit overlap among the committees. But in survivorship, we really focus on the prevention of long-term effects of treatment, so cardiovascular, infertility, immunotherapy toxicities, and sexual dysfunction. We're also focused on looking at reduction in comorbidity and improving cancer outcomes, and also specifically exercise and dietary interventions and other behavioral or survivorship interventions. Of course, a focus on reducing health disparities is critically important in cancer survivorship, as well as looking at mHealth and technology in cancer care delivery. We're also very interested in expanding beyond common cancer diagnoses. Many of the concepts presented focus on breast cancer, which is we welcome, but we also are interested in other cancer types as well as considering metastatic survivorship issues. Want to remind you all that this year it's 30 years of the Hope Foundation supporting SWOG, and if you would take the time to consider donating or supporting the Hope Foundation, you can go to their website. They're also located here in the lobby for more information. We are indebted to the Hope Foundation for providing a number of pilot funding opportunities to SWOG members, especially those focused in the earlier career investigator setting. We have the seed funding, the impact award, the Coltman Fellowship. So consider supporting the Hope Foundation. And here's a little bit more information. You can go to that link and see their toolkit and learn more about the foundation. And a little bit more information there. You want to be a board member. Okay, so let's get to it. I am so delighted to have Dr. Frank Pinedo as our guest speaker here today. Flew in this morning from University of Miami. Dr. Pinedo is the Associate Director of Cancer Survivorship and Translational Behavioral Sciences and the Director of the Cancer Survivorship and Supportive Care Program. He also co-leads the Cancer Control Research Program, all of this at the Sylvester Comprehensive Cancer Center at the Miller School of Medicine. He's also professor of psychology at the University of Miami. His work evaluates the role of sociocultural, biobehavioral, and psychosocial mechanisms underlying disease activity and health outcomes, and the efficacy of evidence-based psychosocial interventions in promoting optimal chronic disease management and health outcomes in cancer. His work also involves translational research evaluating the impact of symptoms and toxicity, monitoring and management in ambulatory oncology, PROs in survivorship care, precision oncology, and phase 1 trials, as well as the implementation of evidence-based behavioral interventions delivered within health systems in the community to improve patient and system level outcomes. He received his bachelor's from University of Miami in psychology, as well as his PhD from University of Miami in clinical psychology, and then went to University of Pittsburgh School of Medicine for his clinical internship in clinical psychology, and has been at University of Miami with a short little detour up to Northwestern and then back to Miami. But he is an expert in cancer survivorship as well as in EPROs, which we are working on within SWOG. And he's one of the most wonderful, nicest person I have had the opportunity, and I'm collaborating with him now. So I'm delighted that he came here today to share with you his research. Thank you.
Thank you, Dr. Irwin, and thank you, Dr. Moore, for the invitation and giving me an opportunity to talk about some of the work that our group is doing down at Miami in the space of survivorship. Today, I'm going to talk about some of the areas that we have focused on. It's certainly, there's a lot more that we're not going to have the time to talk about, but focus more on how can we use PRO assessments to help us guide clinical management of cancer survivors and patients as well. And then talk a little bit about some of the work that we've developed for interventions that are delivered via technology platforms and can be embedded within the EHR, which is the work that's more in development. I should say I have no disclosures to share. So I'm sure you have seen this slide. We've been looking at this slide for a while now. We have seen an unprecedented increase in the number of cancer survivors over the last several decades. Of course, there's a variety of reasons for this, including early detection and treatment efficacy. Currently, we have about maybe 20 million survivors. That number will hit 26 million by 2040, accounting for about 5% of the US population. About 64% of survivors are over the age of 65, so the issue of aging and comorbidities come into interplay with survivorship challenges, and about a fifth of our survivors are Hispanics or Latinos. The benefit, however, that we see in survivorship or longevity tends to be offset by multiple challenges. One of the big challenges we have a provider shortage, not only within oncology, but also within primary care. We don't have enough primary care providers that are trained in oncology to work with the challenges and necessities of our cancer survivorship population. Of course, we're familiar with the chronicity and the burden of treatment-related side effects. I mentioned aging already. Care delivery is also a challenge. Care tends to be not only complex, but care for survivors is often fragmented. We don't communicate with one another, so we don't get an opportunity to provide optimal care in many cases. And we have survivors, particularly those that come from financially disenfranchised communities that have very limited access, not only to cancer centers, but even to primary care where they should be getting some surveillance for cancer. And of course, lifestyle factors play a significant role, and it's great to see that finally there's been really a lot of energy put into trying to understand how lifestyle factors like nutrition, physical activity, and other behaviors play a role not only in the development and risk of cancer, but in the adjustment to cancer treatment and the survivorship experience. So there are multiple survivorship challenges across the care continuum, of course. The good news is that the majority of cancer survivors adjust relatively well, particularly when it comes to emotional well-being. But we know that there are challenges that take place. For example, at diagnosis, we have the uncertainty, the anxiety, the stress of being told that the individual has cancer. And of course, symptoms of depression and anxiety can become prevalent. Lifestyle takes a hit as well, whether it's nutrition, sleep, and other behaviors. At treatment planning, the patient and their family is bombarded with a lot of information. There's decision-making processes that need to take place. There's a lot of treatment options now, which is good, but also it's very complex information for the individual, the patient, and the family to digest. Of course, once treatment begins, we have symptom burden, disruptions to interpersonal functioning, and further down the line, we have the late effects of treatment that are chronic, debilitating. They persist well beyond the peri-treatment period, and also the thought of recurrence and surveillance. Fear of cancer recurrence, as we know, is very common. And there are characteristics or factors that can exacerbate and negatively impact these experiences to our patients: comorbidities, disease severity, social determinants of health, and lifestyle. We also know that premorbid functioning, particularly poor lifestyle behaviors, poor emotional well-being, are very strong predictors of poor adjustment in terms of quality of life in survivors. The challenge that we're faced with is that despite these experiences being prevalent, they're underdetected and undertreated, and that has implications for quality of life outcomes, clinical outcomes, and health system outcomes. This is a pretty large study, about 10,000 adult survivors that documented unmet needs for the patient population. These are mixed patients of various solid and hematologic cancers, and 10 to 70% of the concerns were endorsed by the sample. 40 to 78% reported these concerns as unmet. And as you would expect, some of these concerns or unmet needs, as they were characterized, were fatigue, problems with cognition, sexuality, depression, anxiety, family issues, and issues related to finances. And we are hearing more and more about financial toxicity as a component of the stressful experience of cancer treatment and the cancer experience for survivors. And these matter. We've done some work with the Hispanic community. This is a sample of about 300 Latino cancer survivors of breast, colorectal, and prostate cancers. And we have found that the most common unmet needs that they report are fear of recurrence and concern for close others, particularly family members. But it also matters not only because of the stress, but these unmet needs are associated with symptom burden. So this is associations with satisfaction with cancer care and with symptoms per the FACT B and the FACT P, so the prostate cancer and the breast cancer disease-specific quality of life measures. If we look at physical symptom burden, we find that they're also very prevalent. This is some data on about 1,500 patients that had a hospital visit due to an issue related to cancer. And most patients that were in the hospital that had to be hospitalized were reporting severe or moderate levels of fatigue, poor emotional well-being, and other symptoms. So again, highly prevalent in this cancer survivor population. So we don't have time to go over all the challenges, but this is my colleague, Catherine Alfano, who used to be at ACS, is at Northwell now, came up with this term, which I think really well characterizes the challenge that we have in our hands. We have this perfect storm of all the challenges that I mentioned and really not having the capacity in place to address them. So how do we, as behavioral scientists, as oncologists, how do we work with this to make sure that we can optimize the experience of our survivors? So the National Academy of Science, Institute of Medicine reports have been very influential. They have given us very clear directed mandates that tell us that we need to address by assessing and intervening for physical, emotional, social, financial, and care delivery needs of our patients. We have to make sure that those assessments are patient-centered, they're tapping into the patient experience, and that we have systems in place to avoid care fragmentation via coordinated survivorship and care services. And when I have to say, when negotiating and talking to administrators that hold budgets within my institution, I hang to these mandates for dear life and tell them we need to be accredited by the COC. We have to have this in place. And they come in really helpful because nobody will argue that these are bad ideas, but they don't fall high on the priority list for obvious reasons. When I'm told, should I hire an infusion nurse or a social worker? I'm saying, of course, you need the infusion nurse. So it's an uphill battle, but these mandates are really helpful for us. So we in Miami, like many other cancer centers, have comprehensive survivorship and supportive care programs that meet the standards for accreditation. So they conduct psychosocial distress screening. A lot of them use the distress thermometer. We use some different measures, which I'll talk about. But the essence of these programs is that they have to have in place prevention, surveillance, care coordination, and intervention. And this is not only about symptom burden or the care, the cancer care, it's also about lifestyle and emotional well-being. So it's very, very comprehensive care that has to be delivered. I have the privilege of leading a team of experts. I have Dr. Tracy Crane, who co-leads our cancer control program. She is an expert in lifestyle medicine. On the clinical side, I have Carmen Calfa, Matt Schlumberg, Jessica McIntyre, who's a medical oncologist, gynec oncologist, and nurse practitioner who oversee the supportive care programs. And Brandon Mahal is a radiation oncologist who oversees our community engagement. And we blend these three groups really nicely in an effort to improve patient experiences. So we have our research arm talking to our clinical arm talking to our community, so that we all make sure that we're prioritizing the needs of our patients from the various angles. So we have established survivorship wellness clinics. These are clinics that are pretty comprehensive in the nature of services they provide, but also very tailored to the patient's needs. They include counseling on lifestyle modification, cancer screenings, care coordination, general health assessments, and survivorship care plans. And some of those services are on a referral basis. They're led by an advanced practitioner. They're embedded within a site disease group. When we started thinking years or decades ago about survivorship care, we were thinking of more independent clinics where patients would come in. For some that works, for many it didn't. Patients were confused. They weren't quite sure what care was survivorship, care was going to be taken care of by their oncologist. So we have embedded ourselves within our site disease groups so that the patient feels that they're still being cared by their team, which they are, because that's where our advanced providers live, in the site disease groups, not like in a separate survivorship service. And through these visits, we make referrals for the patient. We found out probably about a year and a half ago, we're looking at the data, over 25% of our patients don't have an identified primary care provider, and that's a required field in their EMR. And we're a NCI designated cancer center, so we have a big patient population that's well insured, but still a quarter doesn't have a primary care provider. In any case, we make referrals to primary care, specialized care, and make sure that the patients are adhering to follow-up guidelines. So with that in mind, I want to talk about some of the programs that we've implemented, focus on ePros, and a program that I didn't come up with the name, but somebody named it my wellness check, and it's stuck, and it's a way of doing risk stratified care by integrating assessments and triaging based on the PRO assessments within the patient records. So there's been a growing literature documenting the benefits of capturing patient-reported outcomes. Not only is it essential to quality medical care to make sure that you have the patient's experience, but I think one of the major driving factors here is that data started coming out showing that if you put a clinician and pair them with a patient, they don't really agree very much on symptoms, particularly the more subjective symptoms like anxiety, depression, and fatigue. So it's been shown that patient-reported outcomes tend to be a bit more accurate and of relevance to the patient relative to a clinician's evaluation. And a growing literature is supporting that if you capture these PROs, it can enhance the patient-provider interaction and communication, and can individualize patient care and improve patient engagement. So the way that we do this, we for those of you that think of value-based care, I have an administrative head as well, so I always have to be thinking of how do we minimize cost, optimize value and outcomes. We focus on patient engagement. How do we optimize providing a service to the patient that's going to keep them engaged within the health system? We capitalize on advances in technology so that we can collect and analyze patient data in real time and robust patient data. And of course, we track outcomes. How does these bells and whistles that we add for ePros can impact patient outcomes? We follow theoretical models or methodology. One framework that we have done that I did actually with my colleagues at Northwestern, led by my colleague Dave Sella, who's there. It was the EPIS implementation framework. This is a dissemination and implementation theoretical framework that allows us to look at how do we put together programs in place that are going to be sustainable over time. And these programs, it's very involved. There's a lot of wording here. The point here is that there's several phases to this dissemination and implementation approach. You start with an exploration phase where you want to make sure that the program has relevancy and it aligns with the priorities of your health center or your clinics. Then you have a second phase where you start doing adoption and preparation, testing what are the barriers, what are the facilitators, and then you move into active implementation and sustainability. My wellness check now is an active implementation, in the active implementation phase. This just very quickly to show you, this is a very involved process where we have multiple stakeholders, multiple steps. It's an iterative process of gathering information and revising as you go along, making sure that you're tapping into the inner and outer context. So inner context being system level factors, outer context being funding, insurance coverage, and factors like that. So how does the system work? So we start by determining patient eligibility via an algorithm that lives within the EMR. It's based on ICD-10 code. We start the assessment at the second visit of the patient. The first visit, usually we get inflated anxiety and distress, so we do it at the second visit, and we don't repeat the assessment more than once every 30 days. The patient gets a reminder by text, email, or phone call, depending on their patient preferences in the EMR, and they're able to do the assessment at home or at the clinic. We started doing this a month before COVID hit. So it was a silver lining was that people got really primed into using technology, and that helped a lot. But our clinic solution took a hit. Our idea was to do this through the EHR, get the patient to do it at home before they come in for their visit. For those that didn't do it through the EHR patient portal, they would do it at the clinic with a nurse. We haven't done the clinic solution yet. We're still catching up because of COVID. So I did want to mention that. The assessment itself takes about 12 to 20 minutes to complete, depending on patient literacy, health literacy, and other factors. And we use several measures to get at patient-reported outcomes, like the PROMIS computerized adaptive test for pain, fatigue, physical functioning, anxiety, and depression. These are brief, well-validated measures that have clinical thresholds that have been established. We do use the Nutri-Score for nutritional needs. We assess practical needs like transportation and childcare, rehabilitation needs, and quality of life using a very brief quality of life measure. The scoring of these measures is in real time. And if the patient scores at a level that's elevated or problematic, other than quality of life, which doesn't generate an alert, but the other measures do generate an alert, and the alert that's generated gets routed to the relevant provider. So if the patient has elevated depression or anxiety, the alert goes to social work. Social work then does a more in-depth assessment with a PHQ-9, a GAD-7, which are more robust, better validated measures. PROMIS are more of screener measures for us. And then if the patient needs a referral, it's either an intervention by the social worker or a referral to psychology or psychiatry. After that, if the patient doesn't get an alert, then we reassess in every 30 days, like I mentioned. So this is a PROMIS, the item banks that we use. I forgot to put the website here, but PROMIS is a system that was developed by the NIH, is widely used. It's very pragmatic. It's more of a screener for us. Dave Sella, hopefully he's not listening. If he's online, I'll probably get in trouble because it's a very well validated measure, but we use it as a screener and then use the GAD and the PHQ to follow. So the patient portal interface, we try to keep it as simple as possible. This is the web-based version. Obviously, we have it in mobile devices as well. So the patient gets one item at a time. And if it's a practical needs checklist, they get a list of items that they can endorse by selecting them. It's fully integrated into Epic. So Epic will record the best practice alerts, the item level responses, the recorded disposition, and a provider and patient-facing trends so that the provider and the patient can see how the patient is doing over time in terms of their scores. So I want to show you some data we have. This is about 10,000 assessments on 6,000 unique patients. What we have found is if you look at their psychosocial and practical needs, coping and managing stress is the most endorsed practical need that they have, followed by insurance issues, general education and information, and transportation resources. Now, the worst kept secret is that nutrition gets more endorsed than any of these. And we actually led to putting in the Nutri-Score because we were getting almost 60 or 65% of our patients endorsing that they needed to talk to a nutritionist about their dietary intake or nutritional issues. So we felt that we needed a more sensitive measure. And I can tell you, Dr. Crane is still playing with the Nutri-Score because it is a complex problem for our patients. If we look at emotional and physical symptoms, it is actually pretty comparable to what we see in other cancer centers, Northwestern, Mayo, Dana-Farber actually have very similar systems in place, and they see about these rates. Keep in mind that these are ambulatory oncology patients, so they're anywhere in the cancer continuum. So as you would expect, the rates of clinically elevated depression, anxiety, and fatigue is not as high as you would see for somebody who's in active treatment or was just diagnosed, and that's why you see those lower rates. So what we have found is that non-responders, people that don't engage, or patients that don't engage with the program, have a greater likelihood of emergency room visits and hospitalizations. And we're not quite sure why that's the case. We have some other findings I'm going to show that hint at that, but we're still trying to understand why that is the case. We have also identified that non-engagement with the program is more common for older participants, as you would expect, if the participant is single, a male, or Hispanic. So we already know factors that are related to lack of engagement with the system. Unfortunately, we don't have measures of computer literacy or anything like that because it's a dissemination trial and we couldn't assess that. So we wanted to see, so maybe there's something that's predicting these ER visits and hospitalizations. And what we find is that unmet needs are associated with ER visits and hospitalizations. So the greater number of unmet needs that the patients have, the greater likelihood of ending up in a hospitalized or an emergency room visit. And these are the multivariate models. As you can see, practical needs predict the ER visit and the hospitalization. If you look at the, I don't think I have a pointer, but sorry about the busy slide, but if you look at the slide, it's the bottom last line. You see that that's controlling for everything above it. They're predictive of hospitalizations and ER visits. We also find that the number of supportive care needs are associated with poor quality of life, as you would expect. So again, there's still a lot to disentangle here. We're looking at referrals, we're looking at dispositions, we're looking at follow-up. But as you can imagine, pulling data from the EMR is a big challenge, but we're trying to do that to see if there's a mechanism here that's explaining those hospitalizations and emergency room visits beyond just engaging with the program and reporting unmet needs. So I want to jump into some of the intervention work that we've done over the past several decades in cognitive behavioral stress management, which is an evidence-based therapy for cancer survivors. And we've done some work in eHealth delivered versions of cognitive behavioral stress management in breast and prostate cancer survivors. Just to give you a brief overview of the model, the conceptual model is that cancer treatment and a cancer diagnosis can be stressor, and that if we provide a treatment, a psychosocial treatment that addresses communication skills, self-efficacy, controllability, social support, and factors that we know favorably impact outcomes, can have an impact on not only emotional and behavioral adaptations, so not only improve anxiety and depression, but perhaps also lifestyle factors, and that through physiological mechanisms can impact quality of life and clinical outcomes. Of course, these interventions vary depending on the disease type, if it's localized versus metastatic, the disease site, if it's reproductive cancer versus hematologic cancer. But the components and the mechanisms and the toolkit, if you will, is pretty similar. And this is backed by a lot of theoretical work that has gone into develop these interventions. The interventions have been traditionally delivered in person. They're manualized in time sequence, typically last 10 sessions, although there are 8-session, 12-session versions, and it's typically led by a master's level psychotherapist. So we have been able to disseminate key findings of this work to community audiences through manuals that have been produced and disseminated. And we have found that cognitive behavioral stress management in stage 1 and stage 3, it's stage 1 through 3 cancer survivors has been associated with improvements in quality of life, stress management, coping, mood, benefit finding. When we get to clinically significant improvements, the findings are less clear, and we find that the intervention seems to benefit those that need it the most, something that would be logical and you would expect. But we thought that this was going to be a silver bullet, end-all be-all for all patients, but that's not the case. So if we're looking, for example, in prostate cancer for improvements in sexual function and emotional well-being, which is not reported very highly in prostate cancer. We only find significant effects for patients coming in with interpersonal deficits, high levels of anxiety, or personality features that are indicative of not having good interpersonal skills. So we took this work and we said, can we deliver this in advanced or metastatic disease in older men with prostate cancer? And can we do this online? Can we bring these men in for an assessment, give them a tablet and have them engaged? This is pre-COVID, 2016, 2015, when we started this. As you can see, it's a very simple, straightforward interface. So I'm going to show you some of the components and some of the findings that we have with a sample of 200 men, about evenly split between metastatic and advanced disease. Patients were randomized to cognitive behavioral stress management and health promotion, when we naively, and I reiterate that, thought that health promotion was going to be an attention control condition that wasn't going to have any effect on anything. So that's not what we found. The interface is very straightforward. Again, we try to keep it as simple as possible. So there's the week sessions that the participants can access to go into a live group with the therapist or to view recordings. And then we have a library of recordings for topics specific to prostate cancer, stress management, coping, et cetera. This is just some acceptability data that we collected in the initial, I believe, 60 patients that we enrolled. So we had pretty good ratings in terms of confidence and efficacy about the material being provided, not only in the experimental condition, but also in the health promotion control condition. So we didn't find a whole lot here. We found the greatest finding here for me is that we can engage these patients. Our average attendance was almost 8 sessions. The average age here was 68, 69. Advanced and metastatic prostate cancer, lots of comorbidities. So it was a good signal for us that we were able to engage these participants in these types of interventions. So we were able to find a group by time effect on relaxation skills. Well, and that's an obvious one because that's what the experimental condition did. But look at this, across both conditions, both the health promotion and the stress management, we found effects on anxiety, total anxiety, prostate cancer-specific anxiety, and fear of progression. And we did not expect that. And keep in mind that the stress management intervention is a psychotherapeutic intervention. The health promotion was a lecture component that basically provided psychoeducation on the benefits of proper sleep, proper diet, proper exercise. And many of these participants were telling us that this is the first time they actually sat in a group with other prostate cancer survivors talking about these concepts. So a lot of this was very new to our participants. And then we found some other moderation effects. Metastatic participants in health promotion showed improvements in fatigue. So again, we taught them the benefits of engaging in proper sleep, proper physical activity and nutrition, and that probably explained that. We also found effects across both conditions in inflammatory cytokines known to be related to symptom burden. All these men, by the way, were on ADT, so their symptom burden is exacerbated by the hormonal challenges that they have. So these cytokines, inflammatory cytokines, have neurotoxic effects that affect fatigue, depression, and other outcomes. We didn't find a direct relationship between these and those outcomes, but we did find significant decreases at the 6-month follow-up, which rebounded at the 12-month follow-up after the intervention. We found the same thing with IL-8, which is an androgenic cytokine. And then we looked at extremes. We wanted to say, okay, is it that CBSM is missing the mark here like we did with localized disease? Remember, with localized disease, our clinically significant effects are only in men that come in with a deficit in interpersonal function, communication skills, high anxiety. And here we found somewhat similar patterns where we found that the extreme groups defined as having high promise depression or low EPIC scores, which is a prostate cancer quality of life instrument, participants showed improvements in urinary function only in the intervention, but then again in CBSM and HP showed improvements in hormonal function, depression, and bowel function. So it was not that even the extreme groups are going to benefit more from the cognitive behavioral stress management. So I'll wrap it up. I don't have, I'm good. Okay. So I want to finalize with the intervention being culturally adapted. This is a trial that we just finished. So we asked the question, can we deliver this intervention for less acculturated, defined by Spanish monolingual Hispanic men with prostate cancer? Just a few words about Hispanics and Latinos in the US. There's 60 million of them. It's about 19% of the US population. There will be 100 million by 2050, accounting for a third of the US population. Cancer used to be the leading cause of death. Now it's back to second, but it's right up there with cardiovascular disease. There's about 4 million cancer survivors now in the US. They're less likely than non-Hispanic whites to be diagnosed with the most common cancers like breast, prostate, and colorectal, but they have higher risk for cancers associated with infectious diseases, and they tend to present for any of these cancers with more advanced disease and poorer outcomes, and show poorer outcomes. So several studies have tried to look at what are the factors that may impact this disadvantage, if you will. I hate to characterize it as a disadvantage, but it does put them in a place that they tend to have more compromised quality of life and disease status when they present with a diagnosis. So we know that Hispanics have the lowest rates of insurance coverage in the United States, and that's likely associated with the later, more advanced diagnosis. They, on average, have 3 or more comorbidities, with obesity, diabetes, and liver disease being right at the top. They report a greater burden of poor health-related quality of life. There's issues with acculturation, particularly the more acculturated you become to U.S. culture, the more your healthy habits tend to take a dive. There's cultural factors as well, which as a behavioral scientist is what I'm very interested in. How does culture impact? So we know that there are fatalistic attitudes, lower optimism related to managing a chronic disease, and issues related to family roles, where family interdependence could be a resilience factor, but it could also be a risk factor if the individual is isolated or has a conflicted family system. So a lot of work has gone into the social determinants of health, if you will, and some of the physical and quality of life outcomes, but very limited work looking at cultural factors, and particularly looking at resiliency, and this resiliency buffer any of these effects. So looking at one of these factors, self-efficacy or controllability, which we know is really important in being related to quality of life. This is a model that basically tested the mediation of self-efficacy between satisfaction with cancer care and health-related quality of life. And we find that for the Hispanic sample, again, this is that same sample of 300 survivors, the association between satisfaction with cancer care and health-related quality of life is mediated by self-efficacy. And that's after controlling for a lot of factors. And self-efficacy plays into culture because we know that Hispanics, like African Americans and other collectivistic cultures, tend to have more fatalistic attitudes about cancer and chronic diseases, where they feel their locus of control is external. They don't really have much power over making change. And if that's the case, then you're probably not going to engage in taking the necessary steps. So to do this work, we followed stages of cultural adaptation without going into much detail. You basically look at the literature, do a preliminary adaptation based on what we know about a specific targeted group in terms of cultural or social patterns that may impact some of the mechanisms you're targeting. And then you do a pilot study and refine based on what you find. So right now we're running a trial with 260 Spanish monolingual prostate cancer survivors, which started in person and ended up online. Everything has switched online. So we're having some challenges in trying to tease that apart. But about 60% of the sample, or a little more, is online. The rest was in person. We're also looking at neuroimmune regulation and gene expression based on the premise that psychosocial stress and chronic stress can affect inflammation and can have neurotoxic effects and promote greater symptom burden. And the big question here is, does a cultural adaptation help have more robust effects for the intervention? So we are looking at cultural factors. I mentioned the familism or family interdependence. where the cultural process is that the family should be there for you. There's strong interdependence, and it has a psychosocial implication. And a critical component of that familism is that for the Hispanic individual, and again, I don't want to stereotype, this is just based on what we know conceptually, not very empirically driven, but for the Hispanic individual, they're more willing to adopt change behavior if it's viewed as a benefit to the family system rather than just a benefit to the individual. And there's other factors as well that we address. So how does this look? We have a didactic that's provided on cultural patterns. We talk about cultural stigmas, about cancer and negative emotions, particularly sexual dysfunction and masculinity, and talking about that with the spouse and family, how adages or sayings in Spanish influence appraisal and coping processes. There's a lot of them that reflect denial and avoidant coping, which is not a great thing. How culture influences sexuality, which I mentioned. And we heard consistently, and unfortunately, we didn't have the resources, that they loved the therapist, but they wanted a peer also co-leading the groups. They felt that they would be better, it would be more relatable to them if somebody that had prostate cancer and gone through that experience was leading some of the sessions. So some preliminary effects. This is very preliminary. We just started analyzing the data. We have significant improvements in general well-being, emotional well-being, sexual functioning, and physical well-being. And this is controlling for some relevant factors. This is in a subset of the participants only. This is not the full sample. So in terms of ongoing work and next steps, sticking with the Hispanic story, we have a pretty large Hispanic Latino cancer survivorship cohort study. It's a study where we're recruiting 3,000 Hispanics in Miami and San Antonio in collaboration with the Mays Cancer Center. The rationale for the two sites is to have a very diverse Hispanic representation, where San Antonio will be mostly Mexican. Miami will have about 15 different countries of origin represented in the sample. We're looking at a multi-level model of predicting symptom burden, health-related quality of life, and disease activity, looking at not only stressors and social cultural factors, but also lifestyle behaviors, psychosocial factors, and biological mechanisms. And finally, we have a lot of work going on in EHR integrated and risk stratified assessment and intervention. Not only are we improving patient visualization for engagement, earlier the CTCA and toxicities, I think, was mentioned. We are now working on embedding the CTCA electronically with a patient-facing monitoring tool so that they can track their symptoms. The second image here is a work I'm very proud of a past trainee of mine, Bettina Yanis at Northwestern University, who through an R37 is doing an implementation study of an EHR embedded depression management intervention, which is directly linked to my wellness check. So individuals scoring high in depression through my wellness check get referred to this program if we have permission of their provider to make that connection. And finally, we've developed, again, with Dr. Yanis, Dr. Rena Fox, a couple of colleagues, other platforms which we call Smart Manage, Tools for Healthy Living, which is basically a very basic web-based interface, mobile-friendly, to deliver the intervention, self-administered or driven by a therapist. So with that, I'm sorry if I went over time, but I'd like to thank my long list of colleagues at various institutions. Thank you.
Thank you so much. I'll have you stay here for a minute. Sure. That was a tremendous amount of work, and would love to see how to spread that across the nation and beyond. We have a question at the podium.
Wonderful presentation. Thank you. I work in Wyoming, has the highest rate of suicide in the nation, and we have no access to any kind of mental health professionals. Hospital does not have a single social worker. There is not a psychiatrist in Western Wyoming. How could we implement some of these mental health recommendations that you've highlighted?
Thank you for sharing that. I'm going to revert to your catchment area, which I believe is now under the Huntsman Cancer Institute, and I wonder if you have any relationship, none whatsoever.
Our cancer center is a Huntsman affiliate.
Yeah.
They cannot provide any services for us. I mean, they have their own needs. We are 300 miles away, and telemedicine can help,
Absolutely.
but we've discussed this. They have nothing to offer us.
Yeah, well, that's a shame to hear. I actually just spent some time with Neely Ulrich, the director of Huntsman, and I'd be happy to tell her that that's a problem because Wyoming is now, I think they have 5 states, maybe 6 states, including Utah, as part of their catchment area. And they have a pretty robust operation, at least in Salt Lake City. I would imagine that with this expansion that they would be able to provide some services. But telehealth can be extremely helpful. And recently there was an article about suicidality in cancer survivors, cancer patients and survivors. And I think the rate was 7 times greater than the general population. It is a problem. It's a problem for us that we unfortunately deal with frequently.
I have a question. I'm so impressed with your My Wellness Check and that you were able to roll that out and get the support. There's a mandate to do distress screening and then follow up on that. I don't even know if many cancer hospitals do that, but can you tell us a little bit about how you got the support, the administrative support to actually move that forward? Was there something that you did or said to really convince them? Because I'm sure this was a huge effort.
Yeah, I was very fortunate, or I am very fortunate that I have a cancer center director that understands this. He's a medical oncologist, but he gets this very well. And we followed that EPIS model, so we did it the right way. And I have to give credit to my prior institution, Northwestern, and Dave Sella's team, who's part of that impact program funded by the NCI, which are moonshot grants that were specifically designed to implement this type of work. Following that EPIS model, you start building up the process that engages not only the psychosocial oncology and the individuals that typically do this, but also medical oncology administrators, regulatory folks. So bringing in those individuals into the room and explaining to them, not only is this a mandate, but this is value-based care. And we're going to put our money where our mouth is. We're going to track hospitalizations, emergency room visits, care satisfaction, things that matter to administration and the people that hold the pocketbooks that fund this. I think that's what led to the combination of having a very supportive cancer center director, the experience I had with my colleagues here at Northwestern, and bringing in administration into the mix.
One quick follow-up question. Do you think now that you've had it rolled out for a couple of years, as a patient is newly diagnosed and comes through, they will complete it then so that you might see, because you mentioned that mostly these are patients 2, 3, 5+ years out, but if you approach them at diagnosis, you can intervene earlier. Is that the goal?
Yeah, absolutely. Our big goal here is to develop a phenotype, be able to test using big data methodology. What does a patient look like upon entering into our system or what is the profile of a patient that's going to be indicative of risk? Whether it's the comorbidities, the age, the depression history, so that we can provide the right level of care at the right time. So yes.
So I'm always, uncertain whether or not you lump or split, right? Like, do you try to get more resources to primary care, or do you have separate survivorship programs? Because we see that sometimes that fractionation makes people deprioritize some of the conditions that are more likely to, increase their morbidity and mortality, right? Like their cardiovascular disease. And there are only so many limited resources out there. So, does it make sense to have these separate survivorship programs, or does it make sense to, invest more in primary care?
It's a great question. It's a tough question. I would say, yes, we have to invest more in primary care. The way that we've approached this is we prioritize the survivorship care within our site disease groups. Within those encounters, we talk a lot about what you mentioned, cardiovascular disease, diabetes management, hypertension management, things that typically would occur in primary care. And at the end of the day, we have to get the patient to a primary care provider. But our priority has been creating those clinics within the site disease group. With that said, we have partnerships with primary care Our health system, like many others, has a significant shortage of primary care providers. We paired up with a company, One Medical, that basically provides primary care services. It has a soft affiliation with the university, and we've actually started a pilot of having an advanced practice provider deliver survivorship care within the primary care setting. But I think in answer to your question, prioritizing it within the site disease group, it just addresses the critical components of survivorship, like surveillance and even attention to these cardiometabolic factors, which I always argue, for patients that are treated with very early prostate breast cancer, these patients are probably going to pass from cardiovascular disease, but cancer is such a hit for so many of them that may fall secondary, tertiary to their care. So it's really important that it gets brought by the forefront. And it's very powerful when you're in your oncology setting and they're telling you, look, we took care of your cancer, you're doing great. Let's focus now on your hypertension, your diabetes.
We can do one last question.
My name is Sam Wright. I'm with the Carl Cancer Institute. I'm also the ORP liaison for this committee. I'm wondering, by implementing these ePros, have you seen any sort of rate change for visit completion? Are they more likely to complete their visits? Are they less likely to complete their visits?
We have not looked at that data, and I'm afraid to, just because of the complexity of extracting it from the EMR. But it is, I mentioned earlier, we're looking to see what explains those ER visits and hospitalization. Part of that is looking at the referral disposition for the patient based on the ePro and whether they followed on that. And it's become a challenge to pull that, but that would be related to, I think, what you're getting at. Yeah.
Great. Thank you so very
Thank
much.
Great. You can, you could advance. Oh, we advance.
We can advance,
yeah. Okay, next, our wonderful patient advocate, Lee Jones, is going to update us on what he's been up to.
Thanks for having me, and thanks for coming here late in the evening on a Thursday. So a couple of things I wanted to provide a news flash, which you maybe not have heard. So two of the long-standing members of the SWOG Patient Advocate Committee, Rick Bangs and Hildy Dillon, are both rolling off of their PAC responsibilities and also rolling off on their disease committee responsibilities. They've been here, I think Rick's been here for 10 years, and there are some term limits. And so their term limits have expired. So they're going to be rolling off. And Rick was especially very instrumental in some of the DEI work that got started. And also, for those who've been around for a while, there was a team science training program that Rick was instrumental in starting, which really describes how researchers can work with research advocates to improve the value of the studies that we all do. So for those of you who are newer, I would encourage you to look on the training section of the SWOG website and look at that team science training. For those of you that did it 4 or 5 years ago, wouldn't hurt to refresh your memories on what's going on there. So replacing them, so Rick had been the chair, Hildy had been the co-chair. So now actually the vice chair, now we are going to have 2 co-chairs. Barbara Segura, who started at the same time that I did 5 or 6 years ago, will be a co-chair, and Anne-Marie Mercurio, who probably a lot of you know, she's been around quite a while, will also be a co-chair. So no one was willing to step up and be the chair again because of all the work that was involved, and especially when they saw the work that Rick did. But now we're going to have co-chairs. And Dr. Dizon is our executive officer for the PAC. So I expect there'll be some changes coming up, because I know that Dr. Dizon and I had a discussion last night, and there are some things that we all think could be improved in the way that the PAC functions. We also have community advocates, and I've been thinking about maybe inviting some community advocates here. So you might hear, for example, what some of the unique needs of adolescent and young adult survivors would have, or LGBTQ plus survivors might have, that would help you think about how to structure your studies. And if those of you in San Francisco in the spring, San Francisco, this last year, one of the reasons I suggested that Shelley Fold-Nasso, who's the CEO of the National Coalition for Cancer Survivorship, be a speaker was because I wanted you all to hear from survivors themselves, and actually was parallel with a lot of what Dr. Pinedo's early slides were on the early part of his presentation. So what is it that survivors are saying they need, they want, that they're lacking? I was hoping that would, instill a lot of interest. I haven't seen it yet. Maybe it's still there to come. But, rather than us necessarily pushing out studies, I'd like to see us pulling in studies based on the needs that are out there in the community, not necessarily what our research interests are. So combining those two to have more relevance and pertinence to what the survivors really want. So I'm actually working on more survivorship type of studies outside of SWOG than I am in SWOG. I've said before, we don't have a lot of studies going on here, and I'm glad to be involved in these. The only problem is I wish we were doing them here at SWOG. So one that just got funded was looking at quality of life for metastatic colorectal cancer survivors. Important activity. I'm a colorectal cancer survivor myself, 19 years this year, but that's something that we could have done here. There's one that I just got involved in reviewing the protocol for, was looking at a financial toxicity study for breast and colorectal cancer patients. And then there's a third one, which really hasn't gotten too far, but it's looking at peripheral neuropathy, chemo-induced peripheral neuropathy, and how to deal with that. Having had oxaliplatin, I know how debilitating that can be. And it's really something that patients don't like. And I wish we had some way that we could deal with that a little bit better. Also, I wanted to point out that PCORI, Patient-Centered Outcomes Research Institute, has a lot of research funding available. One of their priorities is looking at health issues of aging in America. And one of our own studies that got initiated here, S2204, is actually being funded by PCORI, and that deals with older patients. I'm also involved in another PCORI-funded study looking at people 70 to 82, whether FIT is comparable to colonoscopy if they've had at least one polyp identified in the past. So again, take a look at the PCORI website. They have priorities that are bubbling up all the time. There may be something there that would be perfect for you to study. And they have, like the one on the FIT versus colonoscopy, it's a $35 million contract. So they have some real money there. So we can do a lot of things, but we got to find out the things that are there and look at their priority areas. And we should figure out ways to jump on those. I guess the last thing I'll point out, Cancer Grand Challenges, which is a combination of Cancer Research UK and the NCI. Every year seems to have been having priorities. This year they identified 9 priorities. I was actually on an early onset cancer expression of interest. We did not get invited to attend to submit a proposal, but there are 2 teams that did. It's important to take a look at that, cancergrandchallenges.org. See what they're looking at funding, because there's, again, a lot of money. These are 5-year, $20 million grants, which I'd like to see us going after and winning and bringing that money into SWOG research. So anyway, those are the things I wanted to talk about. Lots of opportunities out there, lots of needs out there. And, we have a lot of work that we can do. So thank you very much.
And as you could tell, Lee's very knowledgeable and highly engaged. And so as you develop your concepts, you have ideas, please involve him early on. Clearly, he doesn't have enough to do. So thank you, Lee, for all that you do. Okay, so we're going to spend a few minutes on some of the new concepts that have not been fully presented at this meeting. And then after that, we'll update some of the concepts that have been presented or are already active. So we'll start with Laura Graham, who's actually here in person.
And just of note, this is the order of the slide deck. It might not follow directly what was the agenda online. So for the speakers on Zoom as well, if you can just, you'll see the order. Thank you.
Hi, everyone. I think I met most of you briefly in the spring, so I would say this is a new-ish concept, but hopefully we're going to push this forward. So my name is Laura Graham. I'm an assistant professor at the University of Colorado, and I am a GU oncologist with an interest in prostate cancer. So this concept is really looking at vortioxetine to prevent cognitive changes in men undergoing treatment with androgen deprivation therapy for prostate cancer. And I think I got set up nicely by Dr. Pinedo and Lee, because I think this study will both address something that patients really care about, and we're hoping to use a tablet-based system. And Dr. Pinedo nicely pointed out that's going to be quite feasible. So as background, androgen deprivation therapy is the backbone of treatment for metastatic prostate cancer. And for some men with advanced disease receiving radiation therapy for localized disease. And as many of you know, androgen deprivation therapy lowers testosterone. That's its mechanism of action, but that can have a variety of side effects, including detrimental cognitive effects in some men. In one study, about 50% of men undergoing long-term ADT reported subjective changes in cognition. So this is definitely something that patients care about and has significant quality of life impacts. As I said, about 50% of men report subjective changes. We've documented detriments in attention, verbal memory, spatial processing. We actually have limited data from prospective studies, so a lot of this is retrospective. And I think that as part of this concept, we would have the opportunity to really generate some prospective data that, in addition to the therapeutic aspect of this trial, I think would be really quite valuable. Vortioxetine is it's an FDA-approved antidepressant. It affects the serotonin receptor, but in a novel way compared to other SSRIs or SNRIs. Preliminary data, so in the preclinical setting, and this was courtesy of Dr. Murthy, who had championed this concept before me, but this was from the Mays Cancer Institute looking at castration in male rats. And you can see that there's cognitive impairments in castrated male rats and set shifting and novel object location, but that treatment with vortioxetine reverses these impairments. Clinical data, we don't have clinical data in prostate cancer, but in other populations, vortioxetine has been shown to improve several different cognitive assessments in men with mild cognitive impairment who did not have depression. In shorter term studies of vortioxetine, so 6 to 8 weeks in patients who did have depression, there was positive effects of vortioxetine on cognition compared to placebo. And in other systematic reviews, vortioxetine has had pro-cognitive effects compared to other antidepressants. So it doesn't seem to be that this is just an antidepressive effect. And in patients with Alzheimer's dementia, vortioxetine has been also shown to have some mild improvement in cognitive function, again, compared to other antidepressants. So our hypothesis is that vortioxetine will be safe and effective in reducing cognitive impairment associated with ADT in subjects receiving ADT for prostate cancer. I'll go into the study schema, but essentially we're planning on using CANTAB, which I'll go into a little bit, but this is an electronic assessment. It has a series of cognitive assessments. We're looking at the IED and PAL, which will correlate with the same deficits we saw in those castrated male rats. And we'll also look at adverse events and patient-reported outcomes. Kind of a secondary hypothesis will be that genetic and inflammatory biomarkers may be able to predict which men treated with ADT are at highest risk of cognitive decline. So just like Dr. Pinedo showed us, there's some inflammatory cytokines and other markers that we may be able to look at. So this is the schema. So we'll include patients who are planned to receive at least 1 year of continuous ADT. So this is going to include people who have advanced localized disease and metastatic disease. We're going to exclude patients who already have known dementia or mild cognitive impairment or a mini-cog less than 3. And our plan is to randomize to either vortioxetine 20 milligrams daily for a year or placebo for a year. And like I mentioned, co-primary endpoints will be changes in the CANTAB IED or CANTAB PAL. And we have a variety of secondary endpoints, including kind of intermediate cognitive measures, PROs, safety, and inflammatory cytokines. So just briefly about the CANTAB. So this is a well-validated, language-independent, culturally neutral cognitive battery of tests. It's portable. There's multiple methods of administration. So iPad, smartphone, remote website, desktop. I was really delighted to hear that your talk, because I think one of the questions has been whether in an older patient population, if this is going to be feasible, but I think it will be. And so the two main assessments that we're planning on using is this paired associates learning, which is assesses visual memory and new learning, takes about 8 minutes to complete. And then the extra dimensional set shift, which assesses attention and visual discrimination, so about 7 minutes to complete. So I think this is a doable, 15 minutes doable for patients to do in clinic. This is still being workshopped, but estimating a sample size of about 250 with a 20% loss to follow-up rate may achieve our necessary statistical power. Questions for me?
I have a question, and I may have asked you this before, but this sounds like it's focusing on treating cognitive function rather than preventing, right? It's preventing.
Yes. So hopefully it will prevent decreases in those cognitive assessments. So essentially, we're going to take people who we think are cognitively without cognitive dysfunction.
Yeah.
We're going to treat them with ADT, knowing that although we don't have great prospective evidence, that there's definitely subjective and some retrospective evidence that we get detriments in cognitive function, and that treating with vortioxetine will reduce that decline.
Hi, 2 questions. Jamie Myers, University of Kansas Cancer Center. This is a really exciting study. I couldn't wait to hear your talk today. I have 2 questions. One would be, is the CANTAB going to be supervised or independently administered by the participant? And how did you land on IL-6? What was your rationale for that particular inflammatory marker?
So let me say that I am very open to all feedback and suggestions from people that know more than I do. But I think the original thought was that the CANTAB would probably be unsupervised, but be delivered in clinic. And that's how a lot of the CANTAB has been shown and validated. IL-6 was just one inflammatory cytokine. There's been some data in the prostate cancer literature that that's associated with cognitive decline. But again, very open to suggestions on what other correlatives and biomarkers we should be looking at.
Clearly, it's a tremendous need in this patient population. Thank you. Regarding the drug itself, there are some safety signals regarding suicidal ideation, depression, withdrawal syndromes. Will you have safety measures built in? Because I know the IRB is going to ask for that.
Yes, absolutely. And we'll allow for dose reduction and modification, and we can build in some safety endpoints.
Wonderful. And I think you're in the next phase of building out the 10-page and getting it approved by everyone. And we've done that, or we're in the process. Right?
Yes, we're in the process. I think we have some good support, and looking forward to pushing this forward.
Good. Thank you so much.
Thanks, guys.
You know what, before you run off, there's some questions in the chat.
Oh, yeah.
Sorry, questions from the chat. Are you planning a similar study in breast cancer patients?
That's a great question. Maybe this can be some, we can see what the data is generated and make a follow-up study.
And the other question was about the side effect profile, which was just, some of that was just mentioned by the previous question. And assuming there'd be no out of pocket costs, that just any study drug would be covered by the study.
Yeah, and I will say, so this is an FDA approved antidepressant that has been around for many years. So I think paying attention to the safety is important, but we at least do have some experience and knowledge of the drug.
Great. Thank you very much. Our next speakers are attending remotely, so we'll need them to be unmuted. And we have Susanna Zick and Heather Greenlee, who are going to be sharing their concept, testing the fatigue reduction diet. We did hear earlier that fatigue is one of these great unmet needs. And this happens to be an early stage breast cancer survivors, the BETTER study, breast diet fatigue cancer. All right,
Well,
you're live.
We're live. Hi, everyone. Just let you know, I'm going to start this off and then hand it off to Heather. All right, we can do the next slide. So, as we've already heard, fatigue is a big issue. And we're looking at breast cancer, where around in the survivorship, about 30% of people diagnosed with breast cancer experience clinically significant fatigue, even, 10 years or more after their initial diagnosis. It's clearly correlated and has an impact on all areas of function. And disturbingly, it's an independent predictor of overall survivor, even in these breast cancer survivors many years out. And we know that current treatments for cancer fatigue, as we've said, there's not that many, and they're kind of have challenges to their implementation. So based on other studies and also some cross-sectional data that I've done, we have really looked at what patterns are associated with lower severity of fatigue and lower actually incidence of having fatigue. And so we see patterns where you have higher quality diets, more fiber, lower fat, higher in fruits and vegetables, and higher in omega-3 versus omega-6 foods, all seem to support a lower fatigue burden. We have the next slide, please. Thanks. So we have preliminary data in early stage breast cancer survivors. So these are stage 0 to 3. There were 30. It was a randomized controlled trial where we had a attention control that was matched for both the frequency and way of delivery to the diet itself. And this is a 3-month diet. It's isocaloric, and it has at a minimum 5 servings of vegetables. There's a certain number of each that we want them to have, a minimum of 2 servings of fruits, 50% whole grains, and at least 2 servings of omega-3 fatty rich foods, which can be vegetarian or non-vegetarian. This was delivered with 2 15-minute in-person and 6 15-minute telephone by registered dietitians. And we utilize daily self-monitoring checklist as well as food records and 24-hour recalls. And this is just showing our data from our primary outcome, which was fatigue, and then sleep quality using the Pittsburgh Sleep Quality Index was our secondary outcome. And this is looking at the difference between our baseline and 3-month data. And what you can see there that even adjusting for BMI and age, that the brief fatigue inventory, where higher is worse, and anything above 4, by the way, is considered fatigued, that people after 3 months in the kind of bluish-gray group had a significant decrease compared to the attention control, which are our general health curriculum. So these are time by group differences. And you see a similar pattern in sleep quality, where there's a significant and clinically significant difference in the group that got the fatigue reduction diet to the general health curriculum. Okay, next slide, please. So these are our aims for our study that we're proposing in early stage breast cancer. And you can see that once again, we're going to be moving into fatigue as our primary aim. And I'm going to hand it over now to Heather to talk about the rest of the aims.
Great, thanks, Susie.
So we're excited to bring this to SWOG because it's a very fairly simple and straightforward dietary intervention that we think would be a great one to test in the SWOG environment. So our primary outcome or primary aim is to test the efficacy of the 3-month fatigue reduction diet compared to the 3-month general health counseling attention control on patient-reported fatigue at 3 months. Our secondary aim would be to test the diet compared to the control on fatigue at 12 months, but then also to look at other PROs, including sleep, cognition, pain, mood, and quality of life at both 3 and 12 months. And then we want to do some exploratory aims. We want to test the effects of the intervention on biomarkers of inflammation, which have both been associated with cancer fatigue. And then we also want to explore baseline predictors and mediators of dietary change. So we're interested in seeing if things like baseline BMI or baseline physical activity or baseline locus of control would affect the outcome. And also want to see what are some of the mediators during the time of the intervention that might change and influence the outcomes. Next slide, please. So this is our overall design. Our sample size, we're getting ready to meet with Catherine Guthrie, who we've been assigned to as our biostatistician. So we don't really know if this is the number, but this is what, based on our preliminary back of the envelope calculations, we'll think will be somewhere around there. So the study will enroll adult stage 1 through 3 female breast cancer survivors who've completed treatment. Endocrine therapy is allowed. They'll need to score 4 or higher on the brief fatigue inventory, and they will need to, actually that should be under exclusion criteria. They can't eat more than 5.5 servings a day. And I asked Susie about this particular criteria, and that's based on, that's a data-driven point based on the literature showing what's been associated with fatigue in other populations. People need to have a normal BMI, or BMI greater than 18.5, and then they need to be on stable medications. So they'll be excluded if there's other medically relevant causes of fatigue, or if they're pregnant, lactating, or planning to become pregnant. So then people are randomized into the trial to either 3 months of the fatigue reduction diet or 3 months of the general health curriculum. The way that we want to implement the diet is through Zoom or phone meetings with a registered dietitian. The people would have an online daily tracking log, and then we'll use a study website that'll provide a lot of resources to patients to help with their success. And data will be collected at baseline, 3 and 12 months. Next slide, please. So just some of the logistics. We would like to open this up to all SWOG sites or across all of NCTN. The fatigue reduction diet and the general health curriculum will primarily be delivered by University of Michigan staff. But then at the Hutch, we have resources and staffing in place to be able to deliver it in Spanish. So we'll be able to deliver the intervention both in English and in Spanish. And then the website interface, login, and all of the website-based resources can be delivered through our Fred Hutch Cook for Your Life website. Next slide. So where are we on our timeline? We've presented to the Survivorship Committee. We're obviously presenting again today. We have submitted the aims to DCP. We're waiting to get some feedback from them. We're getting ready to have our initial call next week with Catherine Guthrie for initial SWOG biostats input. We're in the process of setting up a meeting with the SWOG communications team and the operations office. And then we're ready to move through all of the other stages. And so we think that we're in good shape to be able to submit this or we're hoping we're in good shape to be able to submit this for a February 5th deadline. Next slide. And that's it. So thank you very much. We're open to any questions and comments.
Thank you. There's
Yeah. Hi, Heather, it's Dawn. I had just a few just questions in terms of thinking about, in terms of your eligibility and design strategy. So one is, fatigue gets better over time for a lot of patients. And so, it's always challenging to know, are you looking at people with persistent fatigue? Like, do you want to have like a run-in for people that have maintained high level of fatigue and then enroll them in the intervention? Or do you want to enroll a lot more patients knowing that a substantial number of patients are going to get better on their own? So like, how do you find that group of people, not just based on a one-time questionnaire, especially if you're giving it after therapy, but people that have persistently elevated fatigue? So that's just something I throw out there to think about. And then the second thing is to really pay attention to their endocrine therapy, because, you know, you're including patients that may have triple negative breast cancer. Maybe they're on Xeloda, maybe they're on Pembro. Like, do you do it after? They could be on some kind of treatment like a PARP inhibitor for a long period of time. You may have patients that are now on endocrine therapy plus a CDK4/6 inhibitor. So do you wait? Like, sometimes they're on treatment now for 3 years, or they may be 2 years. If Ribo gets approved, it could be another year. You know, do you wait until after that before you put them on? And premenopausal women do differently than postmenopausal women. So all of those things lead to heterogeneity. And so you either have to have a very large sample to account for all of that, or you pick a smaller subset to focus on. I mean, there's strategies either way. I just bring that up because some of the complexities of all of that have sort of exponentially increased as that treatment space has gotten more complicated.
Those are good points and good questions. My preference would be to keep it as generalizable as possible, with the risk of having a very large study. But I do think this is a fairly easy intervention to administer. And so I think we want the results to be able to apply to as many people as possible. So we're certainly open to suggestions on what treatment regimens would qualify for this, or if any of them would be excluded. For the first question, I'll defer to Susie on that one. Susie, do you have any thoughts about duration or persistent fatigue?
Generally speaking, we have done 2 screeners, Dawn. We'll do one at baseline, and then we did one at the screen that would be several weeks apart. And we have to wait until a person is off of their first line of therapies before we do it, by like at least 6 months. So we're giving them time to recover from their other treatments, and then they have to remain fatigued both at the screening and we have in the past done at the baseline, but it didn't really kick out that many people. So we started just using the screening with the brief fatigue inventory. So I think that you ask people, are you persistently fatigued? I mean, or are you fatigued all the time? And they tell you yes or no. And that is our first question. And I think they have a pretty good idea about that. So I trust that.
Hey, I'm Jeff Bamberg from Hawaii. I have a simple question. I'm just wondering about the cost of this diet, and would that be a barrier? I know that diets that have more, like 9 servings, are very expensive, and one of my colleagues had to provide, extra money for the diet. So I'm just wondering, is this diet going to be a problem? And thank you.
Did you
I think this is this is a great question. We emphasize to people that they do not need to do fresh. They do not even need to do frozen. They can do canned, whatever is least expensive. And we've had people on the study before who are food insecure. And so we do work with people, and they found it doable as long as they're given individualized resources to be able to do it. As Heather emphasized, this is not a complicated diet, and we're not saying that you need to go out and have some sort of fancy fruits or vegetables. So, yeah.
There was also a question in the chat about that, whether it's possible that the study could include funding to help those patients who struggle to afford the appropriate foods. And then, as a piggyback to the above, are there strategies to increase access to fresh fruits for those who may have barriers, food deserts, et cetera?
So our team has experience with both of those. We've both provided fruits and vegetables. We've provided food to people participating in our dietary interventions. We've also worked with a lot of underserved populations, and so have strategies on how to make things affordable and how to teach people how to find affordable foods. I think we need to think that through. One of the problems with if we conduct a trial and we provide the food to people, then it isn't something that's necessarily generalizable. So I think we would need to weigh that. And I think we can do some cost estimations too to see what it would cost. But I think the goal is to make this something that's available to everybody. The CDC has done a lot of work with some nutrition programs, doing grocery store shopping tours and things like that to show people how to locate affordable food. But points well taken. It's a big issue.
Yeah, and maybe something built into the study to help with, coaching on that. We have another
Yes.
question at the.
Hi, Jamie Myers, University of Kansas Cancer Center again. Very interesting study. And I was particularly pleased that you're also going to assess PROs for cognitive function, because this diet is really similar to what we recommend for better brain health. And as long as you're drawing blood and going to do IL-6, maybe down the line, it might be interesting to look at the omega-3, omega-6 ratio, because that could potentially correlate with either adherence or the impact on cognitive function.
Yeah, great point. We actually will be getting omega-3 and omega-6 and looking at that. So we'll be able to do that. So that'd be great.
This is great. And just kind of a reminder, like, again, as we saw patient needs that, requesting nutrition, the sleep issues, the fatigue, it's all interrelated. And so if we can find like a way to address all of these with a relatively simple intervention, that's fantastic. Okay, our next speaker is also remote. It's Dr. John Kraus. Hello, I see you on there. And this is a brand new concept that he's going to present, looking at GLP-1 agonists in cancer survivors with a BMI of at least 30.
Hi, thanks for the invitation to talk today. And just a little bit about me. I'm at the University of Michigan for the last 12 years after a stint in private practice. We did research, and I was at the Cleveland Clinic. And I right now help run the medical director of the colorectal cancer clinic. And of course, we have a number of survivors, and we just kind of pass them off. And I think some of these ideas, especially the PROs, if we could get anywhere close to getting away from the mountain of paper that we hand our patients and just get it right into the chart, that would be great. So anyway, I guess if you could, I've just met some of these people recently, so I apologize. But really what got me interested in this is the amazing weight loss with semaglutide. So this is from the STEP 1 trial, and this has now been repeated with multiple other GLP-1 agonists. You consistently get a 15% weight loss. If you could move on to the next slide, please. There is, of course, some concern that it's not just fat loss, that there's also muscle loss. I'm sorry, this is really small on my screen, but down so that you do lose mostly fat, you do lose some muscle, but if you look at the percentage of fat loss to muscle, you're still in the positive in terms of maintaining muscle. So go on to the next slide. Recently, or Florgaprone was an oral non-peptide GLP agonist. It has a similar kind of 15% weight loss, a little bit dose dependent. And so we have both injectable and oral agents that could be brought to bear. Go ahead to the next slide. Across studies, it looks like GLP agonists, this is all with diabetes, but the people with diabetes, patients with diabetes do lose weight. And there's also a trend in a meta-analysis that there's going to be some slight reduction in all-cause mortality. There's always a concern when you do something that is this disruptive that something else will go wrong. And at least so far, in large numbers of patients across various different GLP-1 agonists, trending towards reduced all-cause mortality. Go ahead to the next slide. And Dr. Hibbler at Northwestern has done a retrospective review of cancer survivors who have gotten these and showed that people who use GLP had a lower risk of all-cause mortality as well. Not, of course, prospective and need higher level evidence, but this is, again, kind of more evidence that we probably won't do harm in terms of their underlying cancer. Go ahead to the next slide. So this was what I put forward and then helped with. I was helped in terms of defining it. Well, recruit people with a BMI of greater than 30. This is what the FDA label indication is for semaglutide, and choose 3 obesity-related cancers, which are common: colorectal cancer, breast cancer, uterine cancer, stage 1 through 3, in remission from their cancer for at least a month after completion of chemo and radiation therapy. Unclear as to how long we should do after cancer survivorship, because I think we don't need to treat a normal population. Of course, not being actively treated for diabetes mellitus, and the other kind of thing I thought was no weight reduction surgery. The primary endpoints were weight, muscle, and adipose tissue as determined by DEXA, and intolerability and adherence to therapy. Will people drop off? We're looking at a diet questionnaire, physical activity questionnaire, accelerometry, if we can get it at least from their smartphones, a 6-meter walk test to make sure that we haven't impaired function, and then patient-reported outcomes of quality of life, fatigue, depression, anxiety, and sleep. Going to the next slide. And this is just a schema of what I just said. We were talking about within 60 months of the primary therapy, either treat them with a GLP agonist up front with a dietary toolkit and an exercise toolkit, and then that would end the study supplied part of the regimen. And if they went on to a standard of care GLP-1 agonist, they would stay on it. And then, or they start off with the dietary toolkit, the exercise toolkit, and then go on after 6 months. So this has been put together rather quickly, and so I'm sure there's a lot of other ideas that people have, but I'm excited if SWOG will pick this up. I think one big barrier is, will any companies support this? Of course, semaglutide is in short supply. Is there another GLP agonist in the company that'll help sponsor it? So I just, that was it, and I would appreciate any questions and so forth.
Thank you, John. Any questions?
Just because it's Dawn again, what happens when you do a study like this and then the patient comes off? Like they've lost a lot of weight and then you just don't give them the drug anymore. They don't have any access to it. Do they?
Yeah. So
just gain the weight back? Like what?
Most of the people that go off the GLP-1 agonists gain the weight back. There are multiple factors. I mean, I don't know if we'd be able to, maybe they'd be more motivated as a cancer population or not. I'm not saying motivated, but that's kind of that's placing blame, I guess. So I think the weight will come back on, unfortunately. I see this as kind of.
I just don't know how that works. I mean, obviously when you do an exercise intervention or a dietary interventions, people can just relapse or like they lose weight and they gain it back. But this is something that's so profound and acute. I just didn't know how that was handled in clinical trials, if there are any ethical issues or anything about that, what you've seen in general.
I think, John, that was why the suggestion of having the control group, it's really a waitlist control group. So this would be a patient population who is all interested in taking semaglutide indefinitely, but then the study would fund it and then they would have to, or their insurance would have to cover it thereafter. So it's a good point to consider, John.
Oh, no, that's a huge point, because I think the drugs would work for most people. There are, a number of people, depending on which drug, intolerant of it. So I don't have an answer for that point, other than, no, I don't really have an answer.
Hello, this is Bernard Parker from, retired from NCI. I'm hoping to get back to work there. Big question. to follow up with what Don had just asked, will this study be used ultimately if you have positive results to change the package insert, the prescription for this? Because ultimately then you're heading toward FDA work along with your research. Just asking.
So for semaglutide, this is within the package insert, a BMI of greater than 30. So if another drug company sponsor comes up, I don't think this study would be large enough necessarily, and they'd have to spend the money to and negotiate with the FDA to get approval for cancer survivors. And I guess, yeah, that would be great if they would put that on the label, but what happens a lot of time is that it's just kind of accepted and it's an off-label use. So I don't know that that would happen. I think it might be nice.
Just out of curiosity, just because we were talking, does anybody know like what happens with like mammographic density when you lose that much weight that quickly? Like, you know, some other kind of biomarker, but it's complicated because it's fat. Does it related to risk? Like I was just thinking about other things that we measure that are super important in cancer patients and how that kind of weight loss might change that going forward. Just trying to think of other kinds of outcomes of it. Because I mean, I think we probably all pretty much know that they're going to lose weight on this drug, right? But like starting to think about how it might affect cancer patients differently and how that might affect their long-term care. I don't know, like just throwing it out there.
And I think some of us have concerns about what's it going to do for their bone density, for their lean muscle mass.
Right. Other things that we're following that there's not such great data on, right? So.
Right. So I think if we can do a DEXA scan, I don't know, 6 months, once a year for a while, that would be great, and get some longer term data on that. The data I showed for the muscle mass was from the appendix from the STEP 1 study. I hadn't actually thought of the breast density question. I will see if there's any data available on that. In terms of their mammographic follow-up for the breast cancer patients, in general, I would think it would be, I think you're right, they'll lose weight. What will happen to their breast density? Will that make things change? I don't know.
Last question.
I also wonder, this is Sam from Carl Cancer Institute. I wonder if there should be some sort of a eligibility of while they were on treatment, they could not have lost X amount of weight. Because we know that some of the treatments like 5FU for colorectal can cause weight loss, sometimes fairly easily in patients.
Yeah,
and
I think that's
even if they start above 30, if they're still above 30, I wonder if that weight loss during treatment might have an effect.
I think that's a good point, especially for the colorectal cancer, where they tend to lose the weight is right after the operation, that they need a diverting ostomy for some period of time, especially for the rectal cancer patients. So I'll have to think about what would be an appropriate percentage, or maybe if they were stable for 6 months at a BMI above 30, that might be another kind of way to not exclude them, but not make sure that they're not on this downward trajectory of weight loss triggered. Just observationally, pancreatic cancer patients lose weight, gastric cancer patients lose weight, colorectal cancer patients, even with an ostomy, pretty much stay the same, unless they have, bad disease like peritoneal metastases. But I think putting that in there, because some of them do lose a fair amount of weight with their surgery.
I'm curious, before we move on from the group, is there enthusiasm for this concept? Would you put patients on the study? Do you have reservations? Who would be enthusiastic about putting patients on the study? Oof. So, John?
Who would not? See, people are just afraid of
Who would be afraid of putting a patient on this study? Who would be not excited about putting a patient on this study? All right. So we have a lot of non-responders in here, but we have a couple of people who have reservations, and we've yet to see great enthusiasm.
I have one comment. So I have a little concern, but I'm thinking about what Lee Jones, our patient advocate, started with is if patients are wanting this, we probably need more research on this, because they are figuring out ways to take, I mean, there's a shortage of this medication. I, of course, I have my biases towards healthy eating and exercise, but at the same time, we have to do research that's meaningful to those patients.
All right.
But I mean, get my email or whatever, and I'm happy to respond to email or talk offline. I'll put my cell phone in the chat, my email in the chat if people want to reach out with ideas that would make it something that would want to move forward.
And actually, some more people in the chat are also supporting that they feel that patients would want this study. So it looks like there is some support for moving forward. And then thank you so much for all those presentations. And we're going to move on to our updates, and we're going to start with Justin Floyd.
Green advances. Hello, thanks for having me. And we'll keep this brief. I think I have maybe 4 or 5 slides and try to spend most of our time on the last one. So I say hello to everyone for Monica, my co-conspirator. She can't be here, but this is S1501. And this was approved in 2015. So we've been at this for quite a while. This is a randomized trial, 3 arms. The observation arm is closed currently. The randomized arms are open. It's looking for patients with metastatic breast cancer that are receiving HER2 targeted therapy. And they're followed for cardiac dysfunction for a total of 2 years with cardiac assessment with echocardiograms read centrally. The randomized portion of the study is carvedilol versus no intervention. And briefly, these are patients who have metastatic breast cancer. They're either starting or continuing an eligible HER2 targeted regimen, which includes just about everything. We've added and subtracted things, mainly added as we've gone. The key is they need to be high risk, not high risk metastatic disease, but high risk for heart disease. So prior anthracycline use, borderline ejection fraction, age greater than or equal to 65, BMI greater than or equal to 30. They need to be on or have received current or prior antihypertensive therapy, coronary artery disease, AFib, flutter, or diabetes. They don't have to have multiple of those, just one. What's required to get your site set up? After looking at the DART trial, I thought we had a few sites, but clearly we don't have 1,000 sites. So we probably could do better with more sites. But at any rate, it's really simple to get started. Section 13 of the protocol, which is on the CTSU website, tells you how to get started. The only really requirement for your site is that you validate, credential your echo lab. And it's real simple. You basically have 2 echoes on breast cancer patients within the last 12 months, de-identified and submitted through this AG MedNet de-identification software and portal. Once you prove that you can do that, you're ready to go. That has been an issue in the past, but for the most part, I think it's been resolved. So this is where we'll sit for a minute and talk, get everybody out of here quick for dinner. So I'll be brief, but as you can see, well, first of all, thank you for everyone. Thanks to the patients who've gone on the trial. Thanks to all the sites and the physicians that have put patients on. We have 300 patients on the study currently, but you can look at that blue number at the top, 817. We have a long way to go. And you can see our accrual graph for the last 12 months at the bottom. So we're, sputtering along, I would say, is an accurate assessment. Unfortunately, there's probably a lot of reasons for that. But at any rate, this is slower than projected. At the last group meeting, we discussed this, and we had concluded we wanted to do a redesign. Shortly following, DSMC reached out and said, you need to do a redesign, which we figured was coming. And so we did some analysis, and somebody throw a rock at me if I say something I'm not supposed to say, because we have looked at some data. So I'll try to be vague in my comments, so to speak. But let's just leave it. We'll speak in generalities. The event rate across these patients, which remember is cardiac dysfunction, is very low. Emphasis on very. Of interest, when we're looking at the data, Catherine hasn't given me any evil eyes yet, so I'm doing okay. The observational cohort, remember, those were the patients that were on an ACE or a beta blocker at the beginning of the trial, have the highest event rate of anyone on it. Significantly higher, but still the event rate is very low. So we looked at this and we're currently working on a redesign, but our thought is we're thinking about basically closing the randomized portion and reopening the observational cohort and running this as a prospective observational cohort analysis. So all the patients would be on an ACE or beta blocker. That is at least preliminary analysis. Remember, none of this is formal or official, but those look to be the patients that are at the highest risk, which makes sense. I mean, if your doctor has you on an ACE or a beta blocker, it's for a reason, right? So we would look at including those patients, and we would look at potentially doing a combined endpoint of cardiac dysfunction and cardiac events. So we get higher risk patients, and we should have more events because our event is a broader description. And then based on that, we would hope to develop a predictive model of who's going to get this. And I would say from my perspective, the reason to do this is if our preliminary analysis is correct, we're probably over-testing women with echocardiograms that have metastatic breast cancer that are on these agents. And there's a huge cost savings for the healthcare system, potentially, if we could prove that, and a real benefit to patients not having to come in every 3 months for echocardiograms. So it could potentially be a win-win. So more to come, and I'm happy to answer questions on any of that.
Any questions?
We're probably gonna have to keep moving along.
Keep moving. Thank you.
Yeah, thank you. Yeah, we've got a few more things to get through in the last 15 minutes here. Dr. Gunteru is presenting remotely, and she's going to be talking about S2013, the iCheckIt study, which has been a great success.
Thank you very much. Thank you. So many of you have been enrolling to this study. So on behalf of S2013 team, I would like to thank you all. Just to refresh your memory on the primary objective of this study is to both develop and also validate a risk prediction model for grade 3 or higher IRAEs in participants receiving immune checkpoint inhibitor therapy for solid tumors. So just to remind you, this is only for immune checkpoint inhibitors, and now chemotherapy or targeted therapy is allowed. Next slide, please. So our accrual goal is 2,062. This study is activated in August of 2021, and we're accrued 70% so far. So top 2 categories for this study are one accruing from lung, and second one is for melanoma. So hopefully in the future, we're going to add another chemo ICI cohort for lung, GI, and breast. Sorry, not for melanoma there, typo. And dietary fiber survey to evaluate association between fiber intake and IRAEs. Next slide, please. So just to remind the study calendar, so once they register, there is pre-registration work, and also at week 4, 12, 24, and 52, we get basic data along with the patient-reported outcomes. And there is also optional specimen collection, which includes previous tissue for banking, also blood. We recently added stool microbiome. Next one, please. So blood is collected at baseline and 4 to 6 weeks, and another one at the onset of grade 3 or grade 3 or higher IRAEs. This would serve as a big repository for archival tissue and also for blood plasma specimens for future studies. Next one, please. So this is a recent addition of the microbiome. So the goal with this is to evaluate the association of baseline microbiome composition and metabolomics with the risk of development of IRAEs, and also to see temporal changes in the composition and metabolomics of the fecal microbiome from baseline and how it changes with immune therapy and also at the onset of severe IRAEs. Next one, please. So what we're trying to do is we're trying to separate the blood and microbiome consents. We got some feedback that some of the participants are not interested in microbiome. So we're trying to separate these two so that it can be optional, either blood, microbiome, or both. Next one, please. So you may not be able to see, I'll just highlight, as you can see for accruals, where 90% most of our population is white Caucasians. Next one, please. So my question on behalf of our team is, how can we increase minority and rural population enrollment? I think one factor is most of the time, because it's a melanoma participants that are mostly white Caucasian, that may be partly contributing to it. And we also would like to learn from all of you who are enrolling and with other knowledge of running the studies, how we can increase this minority and rural population enrollment.
Thank you. So it seems like adding that chemotherapy cohort, which will cut down on your melanoma population, may help with their enrollment. From my understanding is that if you separate out melanoma and the remainder of the population, the minority accrual is as you would expect. Is that true?
That's, I think, part of the reason. And I mean, most of our enrollment is also coming from NCORE sites too, thanks to all the site members and everyone. So we're hoping that this would help with increasing the minority and rural population. And if there are any other crossing fingers that chemo immune checkpoint inhibitor cohort opens, we want to be proactive.
Thank you. Any comments from the audience? Barriers, other questions? All right. Thank you very much. Quiet audience today. All right. Next, we're going to invite Virginia Sun for discussing SR 2204.
Yes.
I'll let her explain that.
Yes. So we appreciate the time, having some time to share this study. This was a trial that originally went through the Survivorship Committee because it's PCORI funded. It is not NIH funded. We are now in a City of Hope SWOG collaboration mode where City of Hope is carrying the majority of the load. So hence SR 2204. I'm just going to go through this very quickly. It's a 2-arm trial. It is a grant funded through PCORI focused on healthy aging. So this is older adults focused receiving lung cancer surgery and their family caregivers. They are going to be receiving telephone-based physical activity coaching or enhanced usual care, physical activity self-monitoring only. We are using VivoFit as a device to help them self-monitor in terms of their walking program, and we have multiple follow-ups. And, we start the intervention before surgery and we have several sessions after, and we're going to be following them. The intervention is going to be centrally administered using a model that we've used for many of our other studies successfully through trained health coaches with PTOT backgrounds and nurses as well in the post-op sessions at City of Hope. Just very quickly, primary endpoints, it's really looking at 6-minute walk test, and we have a host of secondary endpoints. We are finally contract activated with PCORI, so we're excited to have that starting. WCG will be our central IRB, and we have retained all of our original sites that were in the R01 in the original concept. Some of them, I believe, are SWOG and NCORE institutions. We have many thoracic surgeons across the country that are excited to join. Dr. Dan Raz is the study chair.
I am a co-chair. He is a thoracic surgeon. He actually went to the lung surgeon work group to sort of engage there. So we appreciate the time to just share updates. We hope that we can learn something from this study, particularly in terms of dyadic interventions, enrollment of family caregivers that we could bring to future SWOG trials. Thank you.
Great, thank you. Any questions from the audience? Great, and I don't see anything in the chat either. Our next speaker is also remote, and it's Rena Fox. She presented at our last meeting on an app-supported sleep coach in cancer survivors and their bedroom partners. So we have a lot of studies now enrolling partners as well. And do you want to, Marina, are you on? Do you want to provide us some updates?
I am, yes, thank you so much. And I'm speaking here today on behalf of myself and the full study team. It's Dr. Terry Badger, Dr. Michael Grandner, Melinda Irwin, Chris Seagren as well. So I wanted to say that quickly. So I did have the chance to present this idea at the spring meeting, and there have been a couple updates I'll go through quite quickly. Next slide, please. All right, so very quickly to kind of lay the foundation, the problem is that we know sleep disturbance is highly prevalent among cancer survivors. A recent meta-analysis suggested it's as high as about 60% across multiple studies. Next slide, please. And it lasts. So there was a study done that looked at survivors who were 9 years post-diagnosis that showed that 20% reported poor sleep quality and 50% were reporting sleep disturbance almost a decade out from diagnosis. And a large portion were also reporting sleep medication usage. Next slide, please. Cancer caregivers also experience poor sleep. So the majority of survivors are married when diagnosed. And as a result, as everybody here I'm sure knows, many spouses become informal caregivers, which has implications for their own personal health. If you can click, this is an animated slide. Thank you so much. So this is unpublished data here, but among over 100 cancer survivors in a study that were collected by some of my collaborators, about 2/3 of their spouses and partners were also reporting sleep disturbance. So we are seeing this symptom experience present dyadically as well. Next slide, please. So the problem, and I apologize, I should learn not to use animated slides, but I'll tell you when clicks are needed. There are therapies that work. There are evidence-based behavioral interventions for sleep disturbance, but the problem is that they're designed for clinical sleep disorders, for those who are meeting diagnostic criteria for disorders such as insomnia. They're also very intensive. They require quite a bit of behavior change simultaneously, and there's a critical shortage of trained providers. Click, please. All right. But there's not much available for more minor concerns, which is what the majority of cancer survivors and their bedroom partners are facing. Next slide. So sleep coaching has entered the scene. It's much more recent. It is distinct from therapy. The goal is not to diagnose or manage clinical conditions, but it's much more consistent with general health coaching with a focus on sleep. And there is emerging support for efficacy, but it has not yet been tested among cancer populations. Next slide. So Sleep Reset is a commercially available sleep coaching smartphone application. If you could click, please. It involves 3 primary types of intervention, including tracking and assessment, sleep and circadian education. And then what really sets it apart from other sleep-focused apps is that it also incorporates in-app interactive text messaging with a live coach. So there is a live human component to this intervention. Next slide, please. My gosh, that is small. I'm so sorry. But examples of some of the coach training topics include general sleep and circadian principles, behavioral sleep and circadian interventions like sleep scheduling and sleep hygiene, coaching orientation and techniques like motivational interviewing, and then what I personally consider the most important, recognizing scope of practice and acknowledging opportunities or situations that would require referral for more intensive assessment and intervention. Next slide, please. So this came from an analysis. It was published this year in Frontiers in Sleep that looked at over 560 commercial users of this particular smartphone application. And among these users who were general population, no restrictions, just people who found it all by themselves, after using the program, it was shown that they took 11 fewer minutes to fall asleep, were awake for almost half an hour less in the middle of the night and got in total about 45 minutes more sleep per night. So these are huge effects for behavioral sleep interventions, much more than would have necessarily been anticipated, but we're really excited by these preliminary data. Next slide, please. So that leads us to where I am today. The concept has morphed a little bit since I presented it at the spring meeting, but long-term what I'd like to do is test sleep reset as an intervention for subclinical sleep disturbance among cancer survivors and their bedroom partners. It can be delivered 100% remotely at centralized administration through this commercially available app. I do have buy-in from the industry partner and the app developers. But as I was developing this concept more, one thing that really jumped out at me is that it's a general intervention. And this is something that also came up at our discussion in the spring. It's not targeted in any way to cancer. It's really for sleep disturbance in general. So the question then became, how acceptable is this and how feasible would it be to deliver this to post-treatment cancer survivors who are experiencing sleep disturbance? And this also extended to the incorporation of bedroom partners. Next slide, please. So the population I would propose to target among survivors would be people with a history of any invasive cancer who have completed treatment with curative intent and have a consistent bedroom partner who is willing to enroll with them. And we would use the Insomnia Severity Index as a screener, but we would be looking specifically at those who have scores that indicate there's something going on. There's at least a 1, but they don't meet likely criteria for insomnia disorder. So they're below the clinical threshold for this screening measure. And then for survivors and bedroom partners, both we would require participants to be at least 18 years old. For pilot purposes, we did specifically say that survivors and bedroom partners would need to have their own smartphone device, though I am heavily reconsidering that. Right now, the intervention is only available in English, so that is an eligibility criteria. And then we would have a couple of additional restrictions as outlined on the slide. Next slide, please. Right, so tiny outcomes. The primary ones for this first stage would be feasibility and acceptability with established a priori benchmarks for what that means. And then we'd also want to look at a couple of patient-reported outcomes, including sleep disturbance, daytime sleep-related impairment, insomnia symptoms, as well as relationship quality. Next slide. All right, so we actually submitted this as a seed application in July. It was scored extremely favorably, not quite favorably enough to get funded. So I'm now kind of thinking through what the next steps might be. But I do think regardless of where funding comes from, this would be appropriate for SWOG. It's mission consistent due to the commercial availability of the intervention and centralized delivery. It's scalable, it's highly scalable and easily implementable. And I think this has a high potential to yield a larger funded project down the line once we've established that feasibility and determined if cancer-specific changes are needed to the intervention. I believe this is my final slide. Next one, perfect. All right, forgive me for the fast speaking. I'm trying to be mindful of time and I'd happily take questions.
Thank you very much. Are you planning to do the pilot at your institution or what? How does that fit in?
That's a great question. That was the original plan. However, I've gotten some feedback that it may be more appropriate to expand to 2 or 3 SWOG institutions. I'd be curious to hear what people here think about that, but I think we're leaning in that direction.
And those in the audience, would people be interested in participating in a study like this? We have a participant that wants to enroll, I think. Yeah, so I think there's enthusiasm. I think we're going to have to move on, but certainly we'll bring this up again at our next phone call and kind of try to help you continue to move forward with this. This is fabulous. Thank you.
Perfect. Thank you so much.
Okay, and then I know we're at time slightly over. Good news is we're just going to do like mini blurbs for the coming up ones. Dr. Barakos had to run to something else, but her secondary analysis of predictors of muscle wasting in Hodgkin's lymphoma patients is moving forward. We have spent the last several months addressing barriers to her getting those slides, and we think we've overcome them. So at our next call, hopefully we'll hear from her. I don't think Stephanie Tsai is able to make this call. And to my knowledge, there haven't been any new updates on this collaboration with the Children's Oncology Group looking at continuous glucose monitoring for glycemic control in patients with ALL. So we'll skip that. And then the final one is the study I've been involved with, the triptorelin for protection of ovarian reserve in AYA with cancer. So this is basically similar to the POEM study in which a GnRH analog was used to protect ovarian function during chemotherapy for breast cancer. However, this study is in non-breast cancer patients with a primary endpoint of the anti-Müllerian hormones at 2 years post-cancer therapy, and includes AYA patients with any malignancy receiving cyclophosphamide-based chemotherapy. They will be randomized to a 6-month formulation of triptorelin during chemotherapy versus not. And the pilot phase of the study has received funding from the DoD, and the protocol is in process, and the study should be opening in the next several months. So by our next meeting, hopefully we'll be enrolling patients. So I encourage you all to look out for this study and open it at your sites, share with your colleagues who take care of kids and AYAs, and so we'll have more to come on that. So I'm just going to skip the rest of this. And if anybody else has anything to share, now's your chance. Otherwise, off to dinner or whatever your evening plans may be. Thank you, everybody. And sorry about going over.